Okay, Karthik, you can go.
So good evening, everyone. So today we have just a mini shadow boxing where we can be. I have taken. I am Karthikeyan. I am a DGPG, Department of Emergency Medicine. So we have with us three cases. All cases were seen by our team the last 3 months, and all these cases are hematology cases. So we will it's some basic history so that we try to understand how we need to evaluate such patients. So after each slide, if anyone wants to intervene, please unmute yourself and ask questions. We will try to discuss it. This is actually more of a discussion based session. So so a 29-year-old IT professional, his main complaint is low grade fever for the past 3 months. So this fellow presented some 2 to 3 months back. So he was having low grade fever for 3 months, and actually some history like he was having some instability in walking, and he was feeling low in life. It seems that during that phase of his time, he was having some personal stress and anxiety issues. He felt low, and he had a low grade fever, and he was evaluated in Jaipur and he got evaluated by a neurologist and then a psychiatrist. Next slide, sir. Sir, okay. So his hemoglobin at that time was 13 grams per deciliter. Uh, they have evaluated for tuberculosis. X-ray was normal, ultrasound abdomen was normal, normal thyroid profile, and LFT RFT was normal. They have gone on to do an MRI without a neurology consultation because he had spine issues. But the MRI came out to be fine, and neurologist cleared him, telling there was nothing significant from the neurology side in his difficulty in walking, and all of them were psychogenic symptoms. And he started treatment with a psychiatrist. He was put on multiple antidepressants, 2 or 3, and also multiple antidepressants he was started on. Like I just like to open the session. Yeah, some people might have actually possibly guessed what it could be, but maybe Vishnu, like you want to throw some light, like what are the differential diagnosis or something you'll wish to think medically without thinking of any psychogenic causes in this 29-30 male.
Sir, the problem is I think we have discussed this case before, right? So immediately the differential that definitely comes
Maybe
to my
okay,
mind.
Mehul sir, or Surya ma'am, or
Yes, sir.
Vignesh sir, whoever is.
I think
Uh,
Vignesh could be good because then some sort of bias can be avoided.
if you want any other,
Uh,
without directly going to the diagnosis, if you want any other investigation, or how will you be thinking in the lines of this case? A 30-year-old male, no known comorbidities, some low mood, some disturbances like low fatigability, and then some walking issues are there. Neurology says that there is nothing there. Then basic investigations are normal. He was gone on to a psychiatrist, and he was completely for 6 months on put on multiple antidepressants.
Karthikeyan,
Sir,
any clinical exam findings?
sir, clinically, his power in both the lower limbs was around 4/5. Reflexes were 1 plus. Babinski was a flexor response. As far as for the sensory examination, um, from 4/5, factory distribution of 4/5. And in other senses, proprioception, there is some joint sense loss that was seen in the great toe. And he was unable to stand up at the presentation. Apart from that, cranial nerves are all completely normal. His mini mental state examination was also normal.
I think heavy metals like lead can also present like this. Chronic lead poisoning.
Ma'am, with the hemoglobin of 13, madam, will anemia be not a main
Then,
presenting?
since I know the diagnosis, I have one more question to ask you. Since will your diagnosis present with a hemoglobin of 13?
Well, when we got the case, this is the hemoglobin at the day when he was evaluated outside in Jaipur. That was 6 months back. And when we got the case, the hemoglobin was 9, and that is why people went on to evaluate the hemoglobin and we could get the
So what if
diagnosis.
in the lead poisoning, chronic lead poisoning, the patient tends to develop anemia later on? This is something which has started with, then maybe later on he tend to develop an anemia.
Uh,
No, just a possibility
yeah,
that I'm
it's a
saying.
good, ma'am. It's a good differential.
Chronic
Anyone
heavy metals can also have such vague complaints, sir. Just
uh,
a differential.
uh, oh,
Karthikeyan
that's a
sir,
one. Uh,
even with iron deficiency anemia, it has that pre-latent, latent, and finally when the deficiency actually manifests itself. So just by saying that the hemoglobin is normal, we cannot actually, I think so, I might be wrong. We cannot say for certain that the deficiency is not there. Here probably we'll be looking at a vitamin B12 deficiency, but I think why this poisoning should also be uh, high up in our cards.
sir. Next slide. Next slide. We can go. So he came to AIMS like after 6 months of all this diagnosis has been made, and here they asked for a full workup. Now the hemoglobin was around 9.5 and his total counts was around 4,000 cells. Again, all other investigations were completely normal. And now since his hemoglobin was 9.5, then he was evaluated. His MCV here was around 140. His MC was around 140, then his B12 levels, then immediately since his MCV was so high, his B12 levels were checked and it was around lesser than 100. Although then he was immediately started on B12 supplementation and all. But anyway, prognosis with partial, there's only partial neurological recovery once this severe combined neurological manifestation takes place, there is only partial neurological recovery seen. Anyway, the point with the 13 hemoglobin that we wish to say was there is no actual cutoff between having a hemoglobin and the presence of neurological manifestations. Some might even have quite a normal hemoglobin of 11 to 12 and yet present with neurological manifestations. So just depending on the hemoglobin value and thinking that neurological manifestations might not come is again is there is no direct correlation. That is point one. Point two, these B12 deficiency neurological symptoms usually start with tingling, paresthesias of the peripheral nerves in the lower, in the peripheral distribution, then slowly keep on ascending. So there has to be caution to be given for even small such kind of paresthesia like symptoms. It can be B12 deficient. And this fellow was not a vegetarian, as we commonly think vegetarians are highly prone. He had to be evaluated whether there could be a pernicious anemia as a cause or some other H. pylori infection or any other cause that was causing this B12 deficiency. So so the myths that were broken were being vegetarian, non-vegetarian excludes the cause that he can go for B12 deficiency. Second, normal hemoglobin, even with a normal hemoglobin of 13, when we saw the old records, his MCV was around 115 at that time itself. So, so if someone had picked him up at that time itself, all the psychiatric medications, this potential neurological worsening could have been stopped. So there is no direct correlation between a high hemoglobin, obviously normal looking hemoglobin, and the presence of neurological symptoms. So even if there is an obviously normal looking hemoglobin, doing a peripheral smear and looking at an MCV becomes grossly important. Then thirdly, once neurological symptoms have started to come, there is high unlikely that he is going to have full neurological recovery. And the fourth important point is depression or any kind of memory disturbances or subtle neurological changes are also very highly low mood. Vitamin B12 is one of the reversible causes of dementia. So these are the 4 points that I wish to say. So memory disturbances, reversible cause of dementia. There's no correlation. Neurological symptoms precede even the occurrence of severe anemia. So anyway, he was started. This patient was started, and he was discharged for follow-up. The differential diagnosis, like lead, is a good differential diagnosis, but again they can also have, I think, memory disturbances. But this position sense, vibration sense being affected is quite and patchy neurological distribution with position sense being affected. And I think lead will also have this basophilic stippling. Is it, how much is it? Is it like specific or a sensitive marker, sir? If we have to think of lead, should this fellow be evaluated for lead? Anyone?
I'm just getting here. As far as I understand, I think sensory disturbances are quite uncommon when you think of lead toxicity. It is more commonly
Ah,
associated with motor weaknesses
ah,
and your decreased tendon reflexes. Whereas in the other heavy metal toxicity, something like a mercury or something is where I think you can also start to develop some sort of tremors, the hatters, shakers, and all that they call, and some sort of sensory disturbances. I feel you can get more in mercury poisoning rather than this is what I feel. I don't remember it exactly, but just out of the outside of my mind, this is what I'm thinking.
So Mehul sir, should like if a patient presents like this, should sending lead be essential, sir? What like, ma'am? Anyone like? Do you think it is essential that we send lead with them, like for to let evaluate lead?
See,
Anyone has seen any case like?
first of all, I think we should. I think you are jumping a few steps ahead. I think so. Initially, when you get this kind of blood picture, so it's like borderline pancytopenia. So hemoglobin is down, platelet is down, total count is on the lower side only. So
हाँ sir, हाँ.
we first need to have a systematic approach. So we should not go helter skelter and go start looking at rare diagnosis initially. So initially with first step is always going to be getting a peripheral smear. So that will give you a good idea about the type of anemia, the morphology of the red red blood cells, whether you have any hypersegmented neutrophils. That will give a good clue about what might be going on. Then another useful thing in the initial evaluation, first thing is going to be the MCV. Whenever you are having any kind of anemia, so that will give you a broad idea whether this is you know, uh, MCV is less than 80, more than 100, or in between. So you can go for microcytic, normocytic, or macrocytic anemia. So the differential is going to vary depending on the MCV. So that is one approach. Another approach that the hematology people generally like to do is to look at the reticulocyte count. So the reticulocyte count will help you decide whether the marrow is functioning normally or not. So that has to be adjusted according to the patient's hemoglobin level. So you can use MD calc and all to help you decide whether what the reticulocyte index is. So if it is like more than 2.5, I think then it is an appropriate marrow response. If it's less than 2.5, then there's some problem there. Then you'll have to evaluate with other things also. So because iron deficiency anemia, sometimes the marrow response might not be that good as well. Similarly with the megaloblastic anemia. So it's not just about the immediately going into the aplastic pathway at all. But that will give you a broad framework of how we want to approach this kind of problem. Then you
Sir, just a small intervention, sir. Like none of this, like since this patient was sir, is like there for 6 months, he has received multiple medications and multiple times. The peripheral smear and all was not very significant. There were a few macrocytes that were seen, but a reticulocyte count. So he has taken B12 for some days, then he has stopped. He was on multiple supplementary medications. So those kind of things we could not achieve in this patient per se.
see,
Karthikeyan sir,
there'll be two problems. See, this is a difficult diagnosis. This is sometimes in medicine, no, it will be very difficult to diagnose things in the first presentation or even in the first few weeks, because these are not the first differential that you would think of in this kind of presentation. So, and even when what you're talking about dementia and all, you don't consider dementia in what that's a 29-year-old IT professional. That is that is not the immediate thing that you're going to start thinking of. So if you're somebody's coming after 60 years, then definitely before you start labeling the patient as Alzheimer's, you have to rule out the hypothyroidism, you have to rule out beta deficiency, because these are reversible causes of dementia or dementia-like symptoms. But in 29-year-old, it's very difficult, and you have to appreciate that it's not an easy diagnosis to make. And another few interesting points about this is one thing is that in beta deficiency, I read, I don't remember the exact source of this, but I think around 25% of the beta deficiency that results in neurological symptoms or neuropsychiatric symptoms, they will have nearly normal blood pictures. So they won't have any significant anemia to speak of. So even before
sir, that is one of the learning points, that sir, any neuropsychiatric manifestations with a borderline hemoglobin, he might not have a full normal hemoglobin, but a borderline hemoglobin should we should still consider to have B12 deficiency as a differential, because anything like a dysesthesia, any borderline neurological symptoms with a hemoglobin 12 and 13 is still possible, is one learning point that this case wants to teach.
Yes, and second thing is that we generally we think B12 deficiency. What do we think of? We generally think of anemia, but you have to keep pancytopenia also in mind when it comes to B12 deficiency. So that is another pitfall that can happen. So,
sir, okay, we'll go to the next case, sir, because since so next case, so next slide. Take next slide. So this case, again, this is a 46-year-old. This case was seen within the last 1 week only. 46-year-old gentleman from Meerut, shopkeeper by occupation. He is now presenting with low-grade fever for the past 1 week, fatigue, weight loss, and diarrhea. Fatigue, weight loss, and diarrhea for the past 2 months. Inability to do routine activities over the past 3 months. So the history is for 3 months with worsening over the past 1 to 2 weeks. It's completely normal before 3 months, no tuberculosis, no comorbidities, was not on any medication, non-smoker, non-alcoholic. Given worsening symptoms, he went to a local hospital, got evaluated. So his hemoglobin is 3.4, total cells is 600 cells, platelets 90,000, total bilirubin 2.7, direct was 1.5. Otherwise, enzymes were normal TSH, negative serology workup. Gallbladder was minimal sludge, and he was referred here for myelodysplasia, considering he was a 46-year-old gentleman. He was advised 1 unit of blood transfusion, but the patient attenders refused having a blood transfusion, and he presented here. The next slide. So on arrival, his pulse rate 70, blood pressure again 170. His trials yellow. So he's having temperature of around 100.3 degree Fahrenheit, and a basic blood workup was ordered. So the basic blood workup, before going to next slide, we'll stop this one here. His blood, sir, next slide. Bus. So his hemoglobin was 3.9, total cells is 1380. So his ANC absolute neutrophil came around 600 or 500 something, 660. Platelets were again 90,000, normal venous blood gas. So whoever had seen him in the rat area said this is febrile neutropenia. That is somewhat neutropenia, febrile neutropenia. Started him on teicoplanin, amikacin, and magnex. And because he was also having diarrhea. So they thought diarrhea was the cause. They wanted to evaluate this patient, and transfusion requests were sent for this patient. So, like, anyone thinking of what is the differential diagnosis at this level, or what would you want to see more? What is the investigations that you would like to do for this patient? Vishnu, if you can like open it up, or someone, like, what else do you want to know in this patient?
Sir, first thing, hemoglobin of 3.9. Obviously, I would want to know what are the other parameters also. What is the baseline MCV of the patient?
MCV, the baseline MCV is around 110. And the peripheral smear shows there are two macrocytes. There are मतलब polychromatophils. There is a dimorphic picture, and there is also like anisocytosis is also there.
Sir. So that is definitely one positive finding that you've already got. Other than that, you've already told that the patient had some mild rise of bilirubin, and around 1.2 of them were indirect, if I'm not wrong. So some sort of hemolysis is also actively happening in the patient, which I feel needs to be evaluated, seeing that the patient is being symptomatic. I mean, has been some worsening of symptoms in the last 1 week. I would like to send some serum LDH, then some peripheral smear to look for chances of any hemolysis. And I will also take some samples and keep for possibility of doing some DCT, ICT, and before.
If you
any
are
transfusion.
thinking of hemolysis, what is the type of cell that you would expect, Vishnu? Like if there is hemolysis,
Some
what
sort
would
of
you?
some schistocytes, some broken down RBCs, and all is what I would like to find, sir.
Okay, if there are schistocytes, then it is predicted that that's an intravascular hemolysis. So anything greater than 2% is significant for an intravascular hemolysis. So DICT, TP,
Yeah, and
HUS.
also something like a serum haptoglobulin, if I am finding to be very low in these patients or something like that. The patient has hemoglobinuria. You can get a basic urine routine to do all that. I think you can go in terms of hemolysis also in this patient.
So,
But what hemolysis doesn't explain is that why he's having a low total counts per se. And seeing some sort of hemolysis and thrombocytopenia in the patient, you should be thinking in terms of TTP, HUS, and all as well. We look for some renal dysfunction in the patient. INR, we are not expecting. INR APTT, we are not, I think, per se expecting to be abnormal in TTP and HS, if I'm not wrong. But some sort of a renal dysfunction is what I'm predicting in this patient. If I'm thinking along lines of HS and TTP, which I want to see. So these two will be my top of the line. One will be something like a vitamin B12. I mean, seeing that his MCV is rising. And just 5 minutes before, Mehul sir has already told that vitamin B12 deficiency can present like a pancytopenia-like picture. And the second would be like hemolysis and why the patient will be developing hemolysis. And I think I've already told you how we would like to work up the patient further if hemolysis happens. Yeah, that's it from me.
Good thing. Sir, next slide. So will you accept for differential diagnosis in this order, or would you want to put one thing above, one thing below? So myelodysplasia, because that is what the peripheral hospital.
Tropical infections, yes, definitely a possibility. Seeing that the patient has thrombocytopenia, some sort of a leukopenia, which they are expecting in, say, dengue fever or something like that. Tropical fever would also be on the top of my list. We can send for tropical fever workup as well. I forgot to think of that. Myelodysplasia, leukemia, and all would go down, sir, is what I would say.
Idiosyncratic reaction and bone marrow suppression, platelets are low, TLC is low, hemoglobin is low.
Bone marrow suppression, I think we can get an idea with the retic count to see how the bone marrow is.
Okay, nice. So we want a retic count here. Okay, we want a reticulocyte count because that is a poor man's bone marrow. We are unable to do a bone marrow in the emergency, so we need a poor man's bone marrow. So we need a retic count. That will give us a lot of like knowledge about this. We need a peripheral smear. We need a retic count, and yes, hemolysis hai nahi hai dekhne ke liye we can do an LDH. And bilirubin is also an indirect marker because we don't. I don't know whether we have haptoglobulin. We can do haptoglobulin and all. So we can do an LDH. LDH will give us a
not
picture.
available in our AD. We'll have to send it outside, sir. But it's a pretty
so LDH, like obviously MCV, MCHC is already there. Peripheral smear, a reticulocyte count, ruling out malaria. That is definitely for sure. And also clinical examination we'll have to look if there is a spleen or not. And okay, so myelodysplasia, tropical infection, whether it is a bone marrow suppression and nutritional. This is how we would go. Next slide. So this is the values. So it's a peripheral smear. This is exactly I have cut copy pasted. Came back RBC sparsely populated, distributed, moderate anisopoikilocytosis, macrocytes 2+, polychromatophils 1+, teardrop cells 1, MCH 40, MCV 115, 2.8 bilirubin in the direct, indirect is 2. Corrected reticulocyte count is 0.4. LDH is 998. Ferritin came as 300. TSAT transferrin saturation. So the normal is lesser than 15 shows that the patient needs iron. Iron divided by TABC is TSAT into 100. No blast, no malaria parasite. Ultrasound, portal hypertension. So again, for everyone, CLD, important differential diagnosis, and always any anemia in an elderly middle-aged male, do stool occult bladder. So portal hypertension, CLD, varices, we never know if he is bleeding from that. So again, anyone wishes to now pinpoint a diagnosis here, or like want to rearrange the differential diagnosis into any other order? I know since everyone knows the topic of the class, they might be skewed towards a diagnosis, but with all the differential diagnosis, or if any other information anyone needs. Okay, I will do the honors. So the point here is, one, we have an MCV of 115 and an MCH of 40. And this patient also has some macrocytic RBCs. Although it is not, there is no word like megaloblastic picture, macroovulocytes. These kind of words which are very specific for B12 has not been given. Any kind of hemolytic picture can present with anisopyclocytosis. And second, what we see here is the reticulocyte count. So the corrected reticulocyte count, if you ask in the pink form itself, they themselves give the corrected reticulocyte count. That is like the reticulocyte count in numbers into patient hematocrit divided by the normal hematocrit. So the value is like somewhere around 1.5 is like a normal bone marrow. Anything lesser than 1 would be considered like an hypoproliferative bone marrow. If it is a normal, or if the reticulocyte count is very high, that means the body is trying to produce a lot of RBC. That means there is some kind of a hemolysis. There is some kind of someone is giving iron or some kind of a replacement therapy, and the body is producing a lot of immature RBCs. But here, the proliferation is having some kind of an issue. It can be an aplastic picture, it can be a myelodysplastic picture, it can be because of some kind of nutritional deficiency that the reticulocytes are not being produced. So, low corrected reticulocyte count with a moderately elevated LDH showing some destructive hemolysis of the immature RBCs, with a bilirubin, that is indirect bilirubin, being mildly raised with an MCV of 115 and without any evidence of portal hypertension. Next, we went on to do a vitamin B12 for this patient. So next slide. The B12 came as lesser than 100 and with the normal folate levels. So as Mehul sir was telling, this patient was a classical case of vitamin B12 induced severe pancytopenia, and the patient improved with just 2 shots of B12, and he was discharged with a hemoglobin of around 5 with a total counts of around 2300. So if we had transfused the patient without working it up, we would have lost the entire picture, because after transfusion B12 levels, we are not interfere. If we had thought of some myelodysplasia or of some kind of a bigger diagnosis, we could have missed a basic B12 deficiency, which is masquerading itself like a severe pancytopenia. So B12 can present as depression, B12 can present as severe pancytopenia. And so the one thing we missed is doing a homocysteine levels, which is also available. Higher homocysteine levels show that the patient is having a B12 deficiency, because the pictures many times can be smudged, reticulocyte count in all these aplastic conditions. Higher homocysteine levels, which is also available from the ED, will confirm the diagnosis that this is a B12 minus a bone marrow. Anyway, so if we hadn't done this, the patient would have gone for a bone marrow. A simple 1 to 2 rupee injection, and the patient improved and walked back home after being diagnosed of a febrile neutropenia, and all antibiotics, everything was stopped. So this is the B12. These are the 2 cases of B12. So next slide. Okay, this is my last case. Again, this is a case which I saw some 5 months back. 15-year-old boy in the night shift, severe pain in all fingers for 1 day. What can it be? Any 2 differentials? Vishnu, anything you wish to say? Any differentials or?
Oh, severe pain in all fingers can be literally due to anything. I think it can be like accidental trauma. It can be something of an acute limb ischemia. It can be something like a Raynaud's phenomenon, night, cold weather, and all is happening. I would want more history right, before I can even think of anything else. Is what I
If
would say.
otherwise, I don't know the disease, but he's having some blood transfusions over the past 2 to 3 years.
Sir, can we think of sickle cell anemia?
So yes,
Definitely,
okay,
definitely.
definitely. So it was then the patient attenders bought some papers which showed that the patient is suffering from sickle cell anemia, recurrent dactylitis, which is very common with sickling disease. So the patient presented with dactylitis, severe pain score of around 8/10 he presented. Next slide. Clinically, he was completely normal except for tachycardia. The saturation was normal. He was talking. Everything was within normal limits. History we got 2 IV bolus fluids. We gave diclofenac for pain. We started the patient of oxygen. For this dactylitis, do you think this treatment is okay? His basic lab parameters, if you want to know, his hemoglobin was 6. We don't know what was his previous hemoglobin. His TLC was normal. Otherwise, electrolytes were normal. Clinical examination except for tachycardia was normal. So with the history, we gave him 2 IV bolus fluids. We gave him diclofenac for pain. We started him on oxygen. Are we okay? Is this the right way to manage? Okay, someone has drawn a diagram. But anyway, if the patient is just having a simple dactylitis with just pain, it's an uncomplicated dactylitis. There is no role for giving fluid boluses. We can give a maintenance fluid, but giving boluses excessive hydration increases the risk of causing hyperchloremic acidosis. We know if you give NS, you're going to cause acidosis, more sickling. And so the complications of giving fluid, there is higher chance of the patient developing pulmonary edema if you give along with opioids, because opioids is what we are going to give for pain relief. Opioids is going to cause pulmonary vasodilation. You give more fluids, more chance of pulmonary edema. So point 1, the myth that you need to just rush in fluids, wrong. You just need to give hypotonic maintenance fluids. Giving diclofenac for pain. Diclofenac works very well for mild to moderate pain. But in severe pain, you need it to work. The action has to be quicker. Opioids are preferred. And the patient, these kind of sickle cell patients can have chronic kidney disease. So we never know it. So NSAIDs, it's better we avoid it unless we are sure that there is no CKD. Starting on oxygen. Again, there is no role for oxygen unless the patient is having an acute chest syndrome with a saturation of lesser than 92. If the patient is tachypneic, desaturating, give oxygen. Otherwise, just giving oxygen to a patient with a simple dactylitis or a simple vaso-occlusive crisis. So all these 3 things are myths. Fluid boluses, diclofenac for pain, starting oxygen. All these things are wrong things that we have done. They're all myths that we shouldn't be doing. There should be moderation of fluid. Pain is only by opioids, and starting oxygen is only when there is acute chest syndrome. Next slide.
Sir, I would like to just ask one thing. In this 15-year-old male, by giving two boluses of fluid, are you really worried that it is going to cause acidosis in him?
See, are we really going to see? This question is very difficult to answer, Vishnu. But the general point of view that they have given in managing sickle cell crisis is, if it is an uncomplicated dactylitis or a vaso-occlusive crisis, there is no need to rush in fluids, because there is a lot of thought process that by diluting the blood, you are going to reduce the sickling crisis. So they are telling that don't give fluid boluses or don't overload the patient. Keep the patient euvolemic. If he's dehydrated, give fluids.
Maintaining the patient euvolemic is fine, but giving 2 fluid boluses wouldn't be exactly wrong, right?
Okay, it's not wrong in the sense wrong, but I'm just trying to drive home the point that maintaining euvolemia is important, not trying to excessively hydrate the patient. The patient, if he's
Right.
euvolemic, there's no need for us to give lot of fluids.
Fine, I agree with that.
So next, the hemoglobin was 6. We don't know normal counts. We don't know what was his previous hemoglobin. What else do we need to order? Obviously, everyone is going to order the basic investigations. So here we didn't know at that day, but when we went on to read and we found out doing a reticulocyte count is very essential. Because this hemoglobin, it can be an aplastic crisis or it can be a sequestration crisis. Aplastic crisis can be because of infection, and sequestration crisis is going to be because of increased hemolysis. If there is hemolysis, reticulocyte count is going to be increased. If there is aplastic crisis, it is going to be reduced. That is, the response is going to be muted. So the most important thing is ordering.
Again, your voice is cut off.
The most important thing is ordering a reticulocyte count, and reticulocyte count will decide how we need to manage this patient. And also we have to try and get the previous hemoglobin of the patient. If there is a fall of greater than 2 grams from the last known hemoglobin level, then there is a need for us to think about transfusion of this patient. Otherwise, there is no need for transfusing a patient with a non-complicated vaso-occlusive crisis. So reticulocyte count is an important takeaway point. And what was the hemoglobin? If there's a greater than 2-gram drop. Next slide.
Karthikeyan sir, I have a small doubt, sir, with respect to the use of corrected reticulocyte count. Should we actually use a corrected reticulocyte count, or should we use a reticulocyte production index? Because
reticulocyte production index is much better. Reticulocyte production index, RPI, is a very good indicator because it takes into account the maturation also. It takes into maturation time is also taken into account. So, but if that is not possible, doing a corrected reticulocyte count index is also more than enough. So both are very good. If we are able to do a reticulocyte production index is much better. And the most important thing should be transfused if the fall is greater than 2 grams. If there is a cardiovascular compromise of the patient, if the patient is requiring oxygen and is worsening clinically, then we need to transfuse the patient. And how should we evaluate a fever? See, encapsulated organisms have a higher propensity in these patients who might go for partial splenectomy. Cultures and start antibiotics for Streptococcus influenza, Streptococcus pneumonia, and Haemophilus influenza. Are reticulocyte counts useful? Yes, very, very useful. So whenever you see a sickling crisis, start thinking about reticulocyte count, whether it is a sequestration crisis or an aplastic crisis. And the dose of hydroxyurea. If there is one drug that is useful in this patient, it is hydroxyurea. And we started a dose of 15 milligrams per kg body weight, and we can reach up to a maximum dose of 35 mg per kg body weight. So
my question is, how does it change management?
The
counts.
Which one? I told you now, Vishnu, like if there is aplastic crisis, we mean there is some kind of an infection that has caused, and the production has become reduced. If there is a reticulocyte count that is on the higher side, like 3, 4, that means there is a sequestration crisis. That means there is increased hemolysis happening somewhere. There is sequestration in the lungs. There is sequestration in the spleen.
So you're telling that you will give antibiotics for aplastic crisis and not for sequestration crisis. Am I right?
No,
that is
antibiotic is based. If you have a clinical suspicion of infection, then definitely antibiotics is important. But the management will change whether we need to go for an exchange transfusion, or if there are some other modalities that we need to treat, would be based whether there is a hemolytic crisis or if there is any aplastic crisis. The management completely changes.
So how do you manage an aplastic crisis, and how do you manage a sequestration crisis? In sequestration, you go in for a plasma exchange, like
plasma exchange, double exchange transfusion. And in aplastic crisis, then if there is, what is the cause of the aplastic, whether there is a parvovirus B19 or the other causes of what is causing the aplastic crisis, we'll have to start evaluating. What is the viral infection? Because viral infections are more prone to cause aplastic crisis. So whether it is completely an infective cause, if there is an active hemolytic cause, will be decided, because that diagnosis and management would be hematology management. But in the emergency, differentiating this would be very essential. I would thank you all. I think I did some 10 minutes extra.
Karthikeyan sir, regarding one more thing, since we are concerned about the sequestration and the aplastic crisis, clinical examination of the individual to rule for any painful enlargement of the spleen. I think that would be very helpful. And would point more towards a sequestration crisis. And regarding the role of antibiotics, sir, with respect to, can you please dwell in a little more detail? Because plastic is, I think, generally due to parvovirus B19 infection and all.
Antibiotics, that like there is no active recommendation like when to start. If we are suspecting based on TLC, based on the clinical parameters, if there is fever, how the patient is presenting, then we need to evaluate and treat basically for the encapsulated organisms, sir. If we suspect if it is a parvovirus B19, sir, that would require like furthermore management from the hematology side. I think at the emergency level, it would be for us in differentiating whether what kind of crisis the patient is having. By chance, if the patient is having a hemolytic crisis, then sequestration crisis, then we go on for plasma exchange or double exchange transfusion. But if it is a aplastic crisis, the cause of the aplastic crisis has to be studied. Even salmonella sometimes can cause an aplastic crisis. So antibiotics in infective cause, antibiotics, again, there is no specific guidelines per se, which I am aware, which I will try to see if there are specific markers or guidelines. But with whatever I know, I think this is what.
Sir, and when we send the peripheral smear, was there anything other than the sickle cells that were present, other than any target cells or sickle cells?
In this patient, there were a lot of sickle cell were present, but again, we have to do a HB electrophoresis to see what is the percentage of HBS. I think up to 40 is a trait, greater than 90 is sickle cell anemia. So I think that is not essential in an emergency or in an acute condition. What is the HBS or what is the cells that are present?
Right, sir. I think I might be wrong, but I read somewhere with respect to this parvovirus B19 infection and presence of giant pro-erythroblast. So in the peripheral smear.
Yes, sir. But I think more of theory. I am not sure of the exact management of those giant cell erythroblast or parvovirus B19. But I think parvovirus B19 is spontaneous self recovery is more common. It takes 4 to 6 weeks, but there is spontaneous recovery.
Right.
Thank you. Sir, you continue, sir.
Okay, so one or two things I'd probably add. So in this, the second case, you could see that basically the red tick count is low and there's pancytopenia, so it's a problem with the marrow. But when you combine it with the high MCV, that is when you start thinking of B12 deficiency. So another thing was the LDH. LDH is actually a non-specific marker of increased cell turnover. So it doesn't mean a hemolysis per se. They mean other things also, but in the right clinical context, obviously it points towards hemolysis. And another marker of hemolysis is a decrease in haptoglobulin, which you can also see. But one of the problems with that is haptoglobulin is made in the liver. So in patients with liver disease, haptoglobulin may be low to begin with, and also liver disease by itself can also cause pancytopenia to some extent. So those are some extra points that I wanted to add. And in the emergency department, I think we can discuss other cases also on another day, where how the thought process is when patients will come with anemia or bicytopenia. Because one thing that you should always look for is history of bleeding and how acute the drop in hemoglobin is. So that will give an idea about how acutely we need to treat the patient. So, Guptan, you want to add something?
No, sir.
So all the three cases are like seen and
Karthikeyan, your voice is breaking. I think Karthikeyan's voice is some issues there.
Well, net connection issue, sir. That was my presentation, sir. Thank you so much for the opportunity that we were able to discuss 3 cases.
Okay. So I think we'll stop the recording for now. I think these were really nice few cases. So I think a lot of us enjoyed discussing these 3 cases today.